So clinically, palpating this, often we'll do it with the patient in supine when we're trying to do specific joint mobilizations, joint testing. But it's definitely going to be easier to visualize. Do you mind taking the necklace off for me? And just be able to see what we're doing here first. So. Couple ways I can start. I can go kind of inferior and work my way up. I can go superior and work my way down. If I fall down off of, so upper trap should be one of the easiest muscles to find. Falling down, I get this little ridge here. What is this? Spine of my scapula. And if I follow that medially, what should that be? About what level? T3. Yeah, T3, 4. We should be right in that range. So I can count spinous processes coming up here. I'm going to suspect 4, 3, 2, 1. The way that it's actually feeling, I feel like this might be 7 and this might be T1. So your vertebrae, cervical have specific features, thoracic have specific features, lumbar have specific features, but it's not one specific change, right? My lower cervical is going to be a little bit more like my thoracic. My lower thoracic is going to be a little bit more like my lumbar. So C7 is really the first one that becomes a little bit bigger, more prominent compared to the other ones, and it's going to have a little bit less mobility over T1 than C6 has on C7. So the primary thing that I'm going to do to confirm exactly which vertebrae that I'm on is I'm going to palpate what I believe is C7, T1, and C6. When I flex, I should feel all of those spinous processes become a little bit more prominent under my finger. So I'm going to go ahead and do this passively, and that is exactly what I'm feeling. But when I have him extend, I should feel C6 significantly move away from my finger, whereas C7, it doesn't really translate that far anteriorly because it's on a much more stable T1. Make sense? So even though I came in here and I could be at about 3 or 4, just from my experience with palpation, I counted as if I was on 3, I think, and I realized I was off 1. And my guess was correct with having this finger be my C6. And this is important because C7 will be my landmark when we're doing lateral flexion and extension. And when we're measuring the thoracic spine, we'll also be using the tape measure, and we'll need to know exactly which vertebrae that we're on. The other way we can do it, and especially if they're having more upper cervical issues and we're trying to get familiar with that area, I am going to kind of work my way up. So soft tissue musculature here, bony ridge is the occiput, and I'm going to follow that inferior aspect of the occiput and the bony prominence coming down right here is his suboccipital protuberance. That's actually going to be the moving arm for my lateral flexion of the cervical spine. So I'm looking at this range here. You guys are going to have the option to do lateral flexion either from anterior or posterior. There are reasons why you could do either one. Posterior, overall in the cervical spine, the joints are much smaller, so I feel like it's a little bit harder to truly see your smooth curve like you can when you're doing stuff with the thoracic and lumbar spine. But if there is a significant hinge joint, you can definitely see that better posterior. Anterior, obviously the chin, the neck, you're not getting as much of a representation of the joint movement, but you can see the patient's face and catch if they're wincing and some of the deviations that you might see if you're asking them to side bend and there's a little bit of rotation occurring. You might see that a little bit better from the front. So there are reasons why you can go either way. But for now, we'll focus on doing this from the back because we should start with really making sure we can do this palpation correctly. Because like I said, it's important for a lot of other things we'll do both now and later in the program. So our normal I moved it, sorry. What is our normal motion we would suspect for lateral flexion of the cervical spine? $20, $45, $100. It's one of those. 45. Give you that little clue and you got it. So yeah, 45 bilateral is what we are expecting. Primary compensations would be if there's a rotation component with it. They're going into, usually if you have them side bend and it's rotating, they're kind of gonna flex a little bit with it as well. They usually won't go into extension as much, but they could. Elevation of the shoulder probably means that we're pulling through upper trap levator scap musculature. Side bending of the thoracic or lumbar spine means they're just trying to do more motion. With these ones, these are the only ones that are actually going to be more of active measurements. If I do these in supine, which I do a lot clinically, and I'm not busting out the goniometer to do that, I will completely passively move. It's a lot easier for them to relax in a supine position. But for the sake of this, what we are going to do is they move actively, and then I'm giving them overpressure that also could be completing the motion for them. Sometimes they move here, and then you passively do your overpressure, and they get like 10 more degrees. We will do overpressure in all directions except extension. That is the most likely direction to injure your patient. So again, on the top of that rubric, the general safety usually you have to do something really wonky in most of the techniques to make your patient not safe. But with the hip adductor MMT, cervical extension goniometry, doing that overpressure that you normally do as part of the technique would be something that is not safe for your patient, so we won't do it. So I'm gonna place my hand just lightly on his left shoulder. Can you go ahead and bring your right ear to your right shoulder? Any pain or discomfort there? And then I'm gonna have you stay there, a little overpressure, firm, feels like more of a muscular infeel. Any pain or discomfort? Perfect. Go ahead and do the same thing to the left side for me. Slight overpressure, any pain or discomfort. Firm and feel on both sides. I'm gonna guesstimate that he was pretty close to normal, 45 on each side, so I will preset my goni to 45. We were at C7 was this one here. So go ahead, side bend for me, up to your left. Sorry, you didn't see what way I had my goni set. And he's probably at like 43, just a little bit short. And if I come in and give him that overpressure, that's probably gonna get him to like 44. His scap started to come up a little bit. Now you can go ahead and go to the right side. And then he actually has a little bit more going this way. So he's actually more like 50. Oh wait, hold on. Come back up to the middle. That's what happens when I take off my glasses. Okay, I preset to 45. Go ahead and bend. And yeah, he's probably more like 46 here. And if I overpressure a little bit, he's getting a little bit more without really compensating too much here. So he was not a significant difference. It was more like 43, 44 to the left, 46, 47 to the right. But the end feel I felt going to the left was significantly more firm. So it might be a little bit more of a joint limitation going to the left, a little bit more to the right, or maybe his muscles are just more tonic and tight on the other side. Go ahead, come on around to the front of the table for me. So when we are here, I am now going to use the nose as the the axis, midline of the thorax, and he wanted his drape.
Oh, I got hot.
So midline of the thorax, nose, and then through the eyebrows is going to be my moving arm. I kind of went through all my other procedural stuff. So to the right, we had a little bit more. That was like our 47. Go ahead and side bend to the right for me. And with this, you might have to move your goni to stay on the axis. But my my stationary arm, it doesn't, like, it's still staying perpendicular to the ground, parallel to his thorax, and that looks about the same there. And then go ahead and go to the left for me, and he's coming up a little bit here. And when I'm looking this way, he's actually looking a little bit more limited. I'm gonna give him a little overpressure. Any discomfort with that? So again, when I did it, I did get him to go a little bit further, and we are back more to that 43 range. So again, that overpressure did make a little bit of a difference. Any pain with either of those?
No, just more tight on the right.
More tight on the right side. So what I felt matches what he felt. There was no pain, which is great. If your patient does have pain and stops, and I go and try and do over, I don't feel an end feel, he says, ow, what do I do?
Stop.
I stop, and what's my end feel?
Empty.
If it's ow, and I feel his muscles turn on, and that stops me, what's my end feel? Muscular guarding. So the pain, if it's just the pain, but you don't feel that tissue resistance, it's empty. If there's guarding and he contracts and pain, now it's pain with an abnormal muscular guarding end feel. And then clinically with him, I would also be looking at rotation, flexion, extension. But I would also be looking at his joint mobility versus his muscular length to really see, is it a combination of the two things? Does he have more of a joint problem? Does he have more muscular tightness? Okay. Any questions? All right, like I said, take some time with this one. Definitely go from the back first and make sure we're getting comfortable with that palpation is one of the biggest skills that'll be, like I said, important not just now, but in the future. And then you can compare your results from the front. In this case, they were very similar. So hopefully that ends up being the same for all of us. 1, 2, 3.